around the outside, the white columns, and they're labelled based on the anatomical region they're in, lateral, dorsal, posterior, whatever, ventral columns. Columns, remember, are pathways for signals to go up and down the cord. Okay? The grey matter in the central H, known as horns, grey horns, dorsal, ventral, lateral. Grey horns, these are where you find unmyelinated neurons, you find cell bodies, and you find fibres that cross to the left and right of the cord, generally speaking. There are some fibres that cross. I forgot to mention one name. I'll mention it now just because a disease is involved in this part. There are some fibres that cross through the white matter. And are not labelled on here, but see where that red dot is? That red dot there, I put that there. That little bit of white material there is known as the white commissure, and it's labelled on this diagram. You can see it, anterior white commissure, this bit here. That little thin strip of white material in front of the grey material is known as the anterior white commissure. And the reason why that's important, we'll get to in a minute. Okay? So again, columns, white columns, signals going up and down, ascending and descending. Okay, motor fibers coming down are motor neurons. These are usually called our upper motor neurons. Fibers that are found, motor neurons found within the spinal cord that travel up and down, down, obviously only down, are called our upper motor neurons, right? They come from the supraspinal levels, and we're going to get to the names of all these later, and they're going to go down the cord and end on our lower motor neurons. Our lower motor neurons are found with the cell bodies within that ventral grey horn. Okay, I think we've talked about, so there we go. This is our lower motor neuron starting here. That cell body is part of one of our lower motor neurons, and it goes out to the muscles. But those are signaled to fire by upper motor neurons that are coming down these white columns. Recent texts might even not call those upper motor neurons. Most therapists do call them upper motor neurons because we distinguish between an upper and lower motor neuron disease. Sometimes you might read, rather than upper motor neurons, sometimes they're called premotor neurons. But that's recent terminology is kind of creeping in there, trying to call these premotor neurons rather than upper motor neurons. But by far, the most common terminology you'll hear out there are upper motor neurons. Okay, so we started looking at some of these facts. So on the right-hand side, the pink are names of places where specific sensations go up the cord. Obviously, those pink parts are on the right, left and right. They just sort of separated them here. So the pink on the right are names of specific types of sensation going to specific parts of the brain above the cord. We're not going to touch on all these today. There's such a couple of them. We won't, for example, touch on these. The spinocerebellar tracts. Where do you think they're going? Cerebellum, obviously. Okay? And they are spinocerebellar tracts are responsible for transmitting proprioceptive information to the cerebellum. Proprioceptive information. Do you know what I mean by proprioception, yes? You all know what I'm talking about, yes? Okay? Remember, the cerebellum is non-conscious. We do not sense anything occurring in the cerebellum. So if I sent proprioception to the cerebellum, my consciousness would not be aware of that. I would not be aware where my arm lies in space based only on spinocerebellar tracts. To get consciousness of any sensation, we have to get to where. Where in the brain do we actually perceive consciousness? We actually see, that's a spider on my arm, that's a pinprick on my leg, that's whatever. Where do we consciously perceive things? On the cerebral cortex, right? That's to get to the very, very top of the brain before you can actually know it's there, as it were. But we send sensory signals all over the place, and we react to those very quickly without even knowing we're doing it. Okay, kind of thing. So that's one of the reasons we send some of this stuff to the cerebellum. We're not going to talk about that today. That gets quite complicated. It's not complicated, but it's more complicated than what we're going to talk about today. So the other pink columns, for example, are the anterior spinothalamic, lateral spinothalamic, fasciculus cuneatus, fasciculus gracilis. Okay? These go to various parts which eventually lead to consciousness, but not directly. Remember, before we get to that, on the left-hand side, blue, we'll talk about it in a minute. These are descending upper motor neuron tracts. Okay? And there's various ones of those, and we'll talk about those in a second or two. But let's look at these ascending, these sensory pathways first. A few of them, just very briefly, just to get a flavour for what goes on. Remember, I said in all sensory pathways, no matter what sensation it is, to get from the periphery, the skin, the hand, the foot, the leg, whatever it is, to the cerebral cortex, it goes in a chain of 3 neurons. There's always a first, a second, and a third order neuron. Okay? Always. The first order neuron always brings the sensation from the skin, wherever it is, the muscle, the tendon, the joint, whatever you're looking at, into the dorsal root, into the spinal cord, in one long axon. Whether it's pain, temperature, whatever. Okay, so the first order neurons always come into the cord. Your third order neurons always start in the thalamus, okay, which is deeper than the cerebrum, and take it, cell body, take it to the sensory cortex. So that's your third order neuron. Always starts on the thalamus. Sometimes these are called projection neurons. They go out from the thalamus, take that sensation, whatever it is, to the sensory cortex. We're looking at somatosensory cortex now. Where is the somatosensory cortex? Whereabouts? What lobe? Remember a brain that looks like this, sort of thing? Temporal lobe, yes, frontal lobe, cerebellum, brainstem, right? Okay. Where is our somatosensory? All the sensations we're talking about, pain, temperature, pressure, touch, vibration, tension, force, whatever, where they all go eventually? What part of the brain are we going to here? Somatosensory cortex, which lies right here on a strip, right, just behind that crack. What's that crack called? That separates the frontal and the parietal lobe, central sulcus, right? So it's on the post-central gyrus, just behind the central sulcus. That's where we're talking about now. All our body sensations end up there. In front of there is the pre-central gyrus, right? What's on? What's on that? Motor cortex. That's our motor cortex, is our sensory cortex. So that's what I'm talking about. That strip there of cortex is this thing here. Okay. Now, what changes, unfortunately, depending on the type of sensation, is how you get from the first to the third order neuron. Alright? So, let's look at proprioception first, which is shown on this fella here. This is proprioceptive pathways. Okay, the first order neuron, you see on there, the first order neuron comes in from the foot, for example. I sense ankle proprioception, whatever. That neuron, as it comes in, it takes an upward turn. And it goes up in the dorsal columns. It goes up all the way to the bottom of the brainstem. And it's going to go up, if it's coming from the foot, it's going to go up the fasciculus gracilis, which is you can see here that pink thing right next to the posterior median sulcus. This is the fasciculus gracilis. Gracilis, that column, that part of the dorsal column, takes up information from lumbar and sacral nerve roots. And within that fasciculus gracilis, it is somatotopically organized. What do we mean by that? Can you spell that? Yeah? Somatotopically organized. What does that mean? The motor cortex is somatotopically organized. The sensory cortex is somatotopically organized. What does that mean? Somato is body, right? Like somatotype. Graph, map. Body map. So in other words, it doesn't go higgledy. It's a specific places where it goes up. And you can see here, for example, you can see the sacral, the lumbar, thoracic, cervical, are all lined up in like a body map. These are dorsal columns. The dorsal columns take up proprioceptive information. Okay, so the fasciculus, these fibers travelling in the fasciculus gracilis end in the bottom of the brainstem and the medulla, where another neuron takes over. This, where they end, is known as the nucleus gracilis, shown on here. The nucleus gracilis is the place those first order neurons end. The second order neuron takes over there, crosses immediately to the contralateral side, ascends through the brainstem. We won't say exactly where yet, but we're going to come back to proprioception later because it's one of the most important sensations for therapists, obviously. Okay, it's going to ascend up to the brainstem and end in the thalamus. So that is the pathway for proprioception to get to the brain. First order, second order, third order neuron. It becomes contralateral in the medulla. Okay, so proprioception, for conscious proprioception, ascends ipsilaterally within the cord. Fair enough? The right leg would come up this side, then cross over and go like that, obviously. It's on the other side. Alright? So that's sacral, lumbar and sacral levels coming in, go up the fasciculus gracilis. The thoracic and cervical upper arm and trunk are going to go up the fasciculus cunatus, which is the pathway right next to it. This pink one here. What does cunatus mean? Fascicle bundle, right? Cunatus, as in the cuneiforms in your foot, as in lingual cunis gyrus, etc., etc. What does cunate mean? What's cuneiform writing? Wedge, right? Little wedges, right? That means a wedge. The wedge-shaped piece of material here, as in cuneiforms, are wedges in your foot. Gracilis means slender. Remember gracilis leg? I don't know, whatever. That will remind you. So the arm and trunk information go up here. The fasciculus cunatus, and again it's body mapped. You can see thoracic and then cervical, etc., etc. And that information, those fibers, this could be the arm now, let's pretend, coming up here, it's going to end on a different nucleus. It's going to end on the nucleus cunatus rather than the nucleus gracilis. Simple as that. So there's another nucleus sitting here where arm information goes up to. And everything else is the same. Okay, so you've got fasciculus cunatus, fasciculus gracilis, taking up that information. Now unfortunately these motor neurons that come in, these sensory neurons, these first order sensory neurons, don't just do that. They'll do this. All over the place. This collateral is going to branch off. And where they go, they'll go to the start of the dorsal spinal cerebellar tracts, they'll go to reflexes, they'll go to all over the place. And that's the detail we'll get to later. But for now, this is just the basic pathway of these proprioceptive fibers getting to the brain. Okay, let's look at another two important fiber pathway. Pain and temperature. They both go the same. They're different receptors, they're different neurons, but they both follow the same pathway. So pain and temperature, again, first order neuron comes in. Again, third order neuron goes from the thalamus to the cortex. Okay? But what we get then, different. So here's our first order neuron coming in. It stops. It stops instantly. It stops right there at the dorsal grey horn. So it stops. It's like this. Let's pretend this is it. It's pain, pinprick coming in. It stops right there. Okay. The second order neuron takes over at the segmental level, right in that dorsal grey horn. It crosses to the other side of the cord at the segmental level straight away, and it crosses through the white commissure, the anterior white commissure we just mentioned. That's a place it gets to. It crosses to get to the other side. And then it ascends contralaterally up the cord in the lateral spinothalamic tract. Again, I'm just doing the very basics, which I hope some of you would know this from the classes, and we're going to add the detail later. So sort of maybe it's refresh, I don't know if not. But question?
Where is it considered the second order on that one?
As soon as it takes over here.
As soon as before it crosses over that?
Well, as soon as you get the synapse. This is the presynaptic neuron, this is the postsynaptic neuron. Presynaptic neuron is the first order, the postsynaptic neuron is the second order. Crosses over, ascends all the way to the thalamus, to the brainstem without stopping, in the lateral spinothalamic tract, which you can see here. Okay? So you can see, if I damage the cord here, would I affect proprioception? No. If I had a dorsal column issue, which, for example, the posterior spinal artery supplies blood to the dorsal columns. If you get a posterior spinal artery bleed, and you get the dorsal column damage at a certain level, then everything above that, their proprioception can't get up to the brain. You do not have conscious awareness of where your feet are, for example. If you damage the fasciculus facilis, I wouldn't know where my leg was in space. So they might look at their feet, for example, to walk. You'd have what's the uncoordination? What's that term? Ataxia. Then I might have ataxia, ataxic gait, because I have no idea where my leg is in space. When I walk, I can feel it, and I don't have to look down and see where I'm putting my feet, because I know by my knee joint sensation, my ankle joint sensation, my hip, my muscle spindles, my GTOs, I know where my foot is in space. I don't have to look at tell me where they are. If I don't know where they are, I could have an ataxic, drunken-like gait. Okay? Because I've damaged my proprioception. So those are just a few of our ascending fibers. And we obviously won't mention all of them, the anterior spinal thalamic, the spinal cerebellar, but remember, to get to consciousness, you have to have 3 orders of a neuron. 1, 2, 3. Okay? Third order neuron, thalamus to the cortex. First order always comes in, but depending on the sensation, it goes different places. And so you can see, if you get lesions in different places on this cord, different sides, if you have unilateral lesions, you can have a different sensory dissociation issues. I might lose pain and temperature. Remember, so pain and temperature from my right leg is going to go up this side. Okay? Alright, so those are some of the sensory pathways, and again we'll come back and add some details. Lots more, unfortunately, picky details to add to that pattern of stuff, particularly in proprioception. It gets quite involved. Let's look at very briefly, these blue fibers, these blue motor neurons, upper motor neurons. And we can divide our upper motor neurons, or sometimes called premotor, whatever, into two broad categories, our pyramidal and our extrapyramidal. That's pyramidal, or pyramidal, how do you want to pronounce it? Pyramidal or extra? There's another one, extra. Okay? Two major sort of divisions of these upper motor neurons. Another term sometimes for the pyramidal tract is a corticospinal tract. The corticospinal. And there is a slight difference in some texts you'll see between pyramidal and corticospinal, but we won't go into that now. Okay? So we have upper motor neurons, corticospinal, obviously going from the motor cortex to the spine. We also see another branch, it's really to the it's not. It's part of the pyramidal, no, it's not. I'm trying to make it simple, but there's another pathway we should be interested in, the corticobulbar tract. That's another pathway for motor neurons, upper motor neurons, should I say. So you've got your corticobulbar, you've got your corticospinal, and you've got your extrapyramidal. Corticobulbar goes from where to where, do you think? Obviously the cortex, right? Obviously to what?
The brainstem.
The brainstem. And why do you want to send upper motor neurons to the brainstem? What starts at the brainstem? All our cranial nerves. So our 12 pairs of cranial nerves start in the brainstem and go out to various places in the head, neck, and the vagal nerve, of course, goes around the body. So to be able to activate my face musculature, my tongue, my cheeks, my eyes, my whatever, you're going to have motor fibers, motor commands coming from the motor cortex down to the brainstem. And those travel in the corticobulbar tract. Okay? Okay, let's look at the corticospinal tract. This is blue thing on here. And there's two divisions of the corticospinal tract. Okay? We have our lateral and our anterior corticospinal tract. Okay? Our lateral and our anterior or ventral corticospinal tracts. The lateral is the biggest one. Let's get rid of all this mess. So, both of these, let's look at the lateral corticospinal tract first. Starts in the motor cortex, precentral gyrus, okay? It's going to come down through the brain, through this bottleneck here, very important bottleneck between these these grey things here, which is our thalamus, and here is the basal ganglia. There's a white pathway, a white bottleneck here, where all these fibers squeeze together. Remember, we looked at a cross-section of the motor cortex, and remember the person's feet are in here, and the head and arms are over here. Remember that? So, it's body mapped. So if you look at it, it would be something like this. I don't know, looks like that. Okay? So this just shows fibers coming from here. But there's motor neurons coming from all over like this. They all converge there. At what's known as the internal capsule. Have you heard of that term before? The internal capsule. Big problem for patients with stroke. Very commonplace to have a stroke. Why would I would rather have a stroke, let's say, here, than here. Why? It's obvious, isn't it?
Because it's up in the cortex, it's just going to affect one area.
Exactly. If I affect this place, I affect the person's foot or leg or knee, whatever. If I affect here, it gets everything. It's a bottleneck. All those fibers, they're heading to all of the different parts of the body, are going to converge in internal capsule. If you're going to damage the internal capsule, you're going to affect the whole, which side of the body? Ipsilateral, contralateral? Contralateral. Okay? And they're very common to have strokes in the internal capsule because there's small blood vessels there, and we'll talk about when we talk about cerebral blood flow. Okay, so they all converge the internal capsule. The internal capsule, again, is somatotopically organized, and we'll talk about that later. So they all come down, the lateral corticospinal tract, they all come down, all these fibers, and all the corticospinal fibers, let's say, come down, and about 80, 85, 89 to 90, let's say 85% of them, roughly, will cross here, in the medulla. So 85% roughly of those fibers that come out of the motor cortex go through the internal capsule, and when they get to the medulla, they cross at the other side.
The internal capsule is the space between. Is this
Pathway.
Okay, so it's not like it's just that
It's
path
a
where they all
hole,
go
you know.
through.
Yeah, it's
Okay.
the pathway between the basal ganglia and the thalamus. Okay, packed jammed full with white upper motor neurons coming down. Okay, so they will cross over. Most of these cross over in the medulla, and this plays what's called the decussation of the medulla, or the pyramids of the medulla. The decussation of the pyramids of the medulla. The big pipes, big columns come down the front side of the brainstem, and you'll see a little crossing over there if you look carefully when you do a dissection. So these decussation means what? Roman deca, 10, X. So it's a crossing point, an X-like pattern. Okay? So they'll, most 85-90% will cross in the decussation of the pyramids of medulla. Then those that did cross carry on down in the lateral corticospinal tract. You can see it here. The lateral corticospinal tract. Okay? Here it is. And you can see it here. The lateral corticospinal tract. Okay, they go all the way down the cord and end on the lower motor neurons in the ventral grey horn. So that's how we turn our biceps on. Okay, you can see upper motor neuron, this long line here. Lower motor neuron starts in the ventral grey horn, goes out the ventral root to our muscle. Simple as that. Alright? Now back to the ones that didn't cross over. The 15% or so that didn't cross over. They continue ipsilaterally down the cord. They don't cross over decussation of the pyramids of medulla, they continue ipsilaterally in, obviously, the anterior corticospinal tract. And you can see that here. Anterior corticospinal tract. Right here. Here, that red blob there. Okay? So they carry down, all the way down the cord, but just before, at the segmental level, most of those cross over to get to those lower motor neurons on the contralateral side. You can see them represented by this diagram here, crossing back over. You can see it here. So they carry on down the cord on the ipsilateral side, but they cross over immediately at the segmental level to synapse on those lower motor neurons that the lateral corticospinal tract synapsed on. Okay? So again, control is contralateral. Left side of the brain controls the right side of the body. Simple as that. There's about 5% of this anterior corticospinal tract do not cross over though. A small percent of the anterior corticospinal tract stays ipsilateral. And these are thought to primarily be responsible or go to motor neurons for trunk control, posture, core control. Okay? The ones that don't cross over are innervated trunk muscles. See, some of your muscles, it's a small percentage of a bilateral control of trunk muscles, but it's not majorly, significant. So if I got a lesion, an upper motor neuron lesion above the internal capsule, would the symptoms be contralateral, ipsilateral? I've got a lesion in my left, above my left internal capsule. Symptoms would be where? Contralateral. If I got a lesion in the midbrain or the pons, contralateral, ipsilateral?
Contralateral.
Contralateral. Remember the pons and midbrain are above the medulla, right? So obviously it's going to be contralateral. If I got a lesion in the cord below the medulla, ipsilateral, contralateral? Ipsilateral, largely, yes. Okay? But remember, you're going to have some fibers going down ipsilateral. On the other side. When you get a stroke, or when you get a spinal cord injury, people say the involved side and the uninvolved side. That's not really good terminology. He's saying his involved limb and his uninvolved limb, or his good limb and his bad limb. Really, it's an involved limb and less involved limb, really. Because the other side is going to have it's not going to be normal, because of these other pathways. But obviously, there's one side way more abnormal than the other side. Okay? Now, so that's the corticospinal tracts. The corticobulbar tracts, we'll get to that later, but that's kind of a mess. But just remember about the corticospinal tracts, by and large, there's a bilateral supply. So in other words, the left stuff coming out of the left hemisphere goes to both sides of the brainstem. Okay? And we'll get to that later, but it's not as simple as this. We get a bilateral supply in many of our cranial nerves. The other pathway we didn't mention is our extrapyramidal pathway. The corticospinal pathway is very recent development in man, because we haven't had a cerebral cortex for many years. This is a recent development in evolutionary terms. Lower animals don't have a big cerebral cortex. We've got a huge one, a big frontal lobe, etc., etc. But lower animals don't. They don't have a cerebral cortex, so some of those corticospinal pathways are not possible. They rely on the extrapyramidal pathways, just like we do in some actions. Extrapyramidal pathways do not start directly in the motor cortex. They start lower down in the brain, in various nuclei. And these are much older pathways, more reflexive pathways, more vegetative type of pathways. And these are them, in very, very brief. And these, again, are not as simple contralateral, ipsilateral, bilateral. When we talk about these later on, we'll go over exactly what they do and where they go. But just for now, has anybody heard of these names? I was hoping AP would go over just the basics of this. So these are your four major extrapyramidal pathways. The rubrospinal tract. Where do you think that starts? Where does that start? Obviously it goes out, these are upper motor neurons, okay? Where did it start? It goes to the spine, where's it starting? Rubro means red, the red nucleus. This starts at the red nucleus. This will take information from the cerebellum rapidly down the spinal cord. Rubrospinal tract is a extrapyramidal pathway. The next one will be reticulospinal tract. Where's that going to start, do you think? Reticular formation, or the reticular activating system, right? You've heard of that? What does the reticular activating system do for us? Keeps us awake, level of consciousness. If you damage your reticular formation, you might have a coma, you might have sleepwalking, you might have whatever, all kind of things, weird things that happen. Vestibulospinal tract. Okay, that's obvious. Where's that coming from? The nose, right? No, the vestibular system, obviously. The vestibular nuclei. So what's that going to be important? What kind of information is that going to be conveyed down that tract? Where's that coming from? What information? Vestibular system, balance, right? Balance stuff. Vestibular nuclei receive signals from the vestibular apparatus in the inner ear, and it sends it down the vestibular nuclei. Via the vestibular nuclei down the vestibular spinal tract, right? And then the tectospinal tract comes from a tectum. The tectum. Part of the brainstem that's involved in reflexive movements to visual and auditory stimuli. So when somebody jumps out at you, out of a door and goes boo, or you hear a loud bang and you flinch, it's the tectospinal tract doing that. Or a bright flash of light, or somebody jumps out at you and just startles you, and your hands come up and your head goes back like that. That's the tectospinal tract doing that for you. You do that before you get consciousness. In other words, you don't say, oh, somebody's jumped out in front of me, bring your hand in front of my face, protect myself. No. That's done very low level by the tectospinal tract, by the tectum. Okay? And we're going to get to the details of these pathways, as I say, as we add more and more detail to them. Okay, so those are the extrapyramidal pathways. So, again, extrapyramidal pathways, corticospinal pathways, corticobulbar pathways, they're all upper motor neurons. These upper motor neurons are fibers that take information down the cord or down the brainstem that eventually are going to synapse on our lower motor neurons. Our lower motor neurons they start within the cord, but most of the axon, of course, is going down the ulnar nerve, the sciatic nerve, the radial nerve, whatever it is, to get to those muscles. Okay? If you damage a lower motor neuron, or you damage an upper motor neuron, you'll see different signs and symptoms, very, very characteristic of those lesions. And those type of questions, or the knowledge of these lesions and the signs and symptoms associated with upper and lower motor neuron disease, you're guaranteed to have a question on the board about that. They all ask questions on different upper and lower motor neuron diseases. Is this an upper motor? Is this a lower motor neuron disease? How can you tell this is upper motor neuron? If it is upper motor neuron, what kind of disease is it? So let's just look at some signs and symptoms of let's pick out lower motor neuron first. If you cut your lower motor neuron, in other words, motor neurons coming from the ventral gray horn going to the quads, going to the biceps, going to the brachialis, whatever. Those are lower motor neurons. Obviously, we'll make it a clear black and white cut straight through the muscle, straight to the nerve, I mean. So I'm going to cut all your femoral nerve, let's pretend. It could be a knife wound, it could be a demyelinating disease, it could be whatever, okay? Would you have voluntary control over your quads?
No.
Could I contract my quads if I cut my femoral nerve? Voluntarily, can I send a signal from the brain to the quads and say, contract? No. Of course not. Okay? So you can have loss of voluntary control of the muscle. Now, depending on the severity of it, you might have no control. If I cut your femoral nerve, you'd have no control. But if you have some kind of disease on it, and if it affects some of those motor neurons, you're going to have weakness in the quads, aren't you? And it's going to be complete, depending on the number of motor neurons that are damaged. Would you have reflexive control over could I activate the muscles reflexively? In other words, the patellar tendon tap reflex. I whack the patellar tendon, remember that one? You've done that, yes? OT's done that, yeah? Or biceps or whatever, and the knee shoots up like this. I could cut my head off and you'd still get that, right? It's got nothing to do with the brain. It's just a spinal cord segmental level. I whack the patellar tendon, you stretch the muscle spindles in the quads, the alpha motor neurons, the 1A and type 2 neurons come in and sense and contract the muscle. Would that be okay if with a lower motor neuron disease? Could I have reflexive control, or not control, but reflexive activation of the quads?
No.
Yes, no. Any else? Any other votes? Of course you can't. Why? How on earth could you? You've got no motor neurons going to the quads. How can I contract them? It's impossible. You could sense them. That you know your reflex arc. You know your muscle spindles will detect the stretch. They go into the cord, but there's no There's no neurons to take them out. This thing. So here, let's pretend it's a stretch. This pin is stretched now. Comes in here, comes round and down my femoral nerve to my quads, but I've cut your femoral nerve. So you do not have any activation of the quads. So you have no reflexive control. You have no stretch reflexes. You are areflexic. Areflexia. Would you have hypotonia or hypertonia? Hypertonic or hypotonic? You know the difference, right? With hypotonic, flaccid, weak muscles, less muscle tone than normal. Would you have flaccid paralysis or spastic paralysis? You know the difference? Yes? Flaccid paralysis is this. Spastic paralysis is this, right? The muscle's rigid. Which would you get? Flaccid paralysis. There's no activation of that muscle. Paralysis means what? Power is what? By the side, right? Lysis, death. So paralysis is death by your side. In other words, the arm is dead by your side. So the term comes from. Okay? So you'd have flaccid paralysis. You'd have diminished resistance to passive manipulation. So if I were to grab a normal person's arm and bend it, I could feel some muscle tone there. And in patient, it would be gone. It would be just like floppiness. Resistance, depending on the severity, of course, how floppy it would. You would have severe muscle atrophy. Much more severe than if you had just inactive muscles. What I'm trying to say is, if I was to stick my hand in my pocket for 4 months, my arm muscles would atrophy. If I didn't use my arm for a month or 2, I'd have atrophy of my muscles. Okay? Because I'm not using them. But if I cut my nerves going to those muscles for the same length of time, we'd have way more atrophy than if I just didn't use them. Because motor neurons have a trophic influence on muscle. They keep it alive even if they're not being used. If you cut your motor neurons, you've seen people with spinal cord injuries, right, in a wheelchair, their leg muscles are just like non-existent, thin strips of nothing. Because they have got no motor neurons going to them to give them a trophic influence. Never mind activate them to get them moving. So severe muscle atrophy. You'll see fibrillations and fasciculations in a lower motor neuron disease sometimes. Fibrillations, well, you won't see these, but you see on electromyography, EMG, OT, something like that? Yeah? EMG, you pick up electrical signals out of muscles. You can see fibrillations as minute twitches on the EMG machine. Visually, you won't see them. You won't see fibrillations of patients. These are single fibers twitching, a few fibers twitching within the muscle. Fibrillation, single fibers firing. Okay, you won't see that visually on the skin surface. You will, however, see fasciculations. Those are motor units of firing. Sometimes you get that in yourself, right? Your muscles twitching or your face twitches like that. And you can't stop it and you whack it and it still twitches away. That's a fasciculation. Just without you activating it, just start firing. Those motor units fire. You'll see those in a lower motor neuron disease. If I was to cut your dorsal root, okay, if I cut your sensory fibers, forget the motor neurons now, if I cut your sensory fibers going into the cord, could you have voluntary control over those muscles? So if I cut the sensory nerves of your femoral nerve, could I voluntarily contract my quads? If I cut the sensory neurons. Yes, of course you could. If I cut your sensory neurons, all of them, could you have the reflexive activation of the quads? No, of course not. Because I'm relying on that input from the muscle spindle to contract my quad. That's a reflex, right? If I've cut your dorsal roots, I've cut the information coming from the muscle spindle, you can't contract the quads. Let's look at, before we look at upper motor neurons, let's look at one of the most common demyelinating neurons. Take a little break, look clinically. Common demyelinating neuropathy in the peripheral nervous system. It's going to affect our lower motor neurons, and that was, what's the most common demyelinating peripheral nervous system disease? Guillain-Barré. Guillain-Barré. I mentioned that briefly. A quick 2 points about Guillain-Barré then, because it affects lower motor neurons. Guillain-Barré is a lower motor neuron disease. It also affects our sensory neurons though as well. It affects all nerves within the peripheral nervous system. It's not a central nervous system, it's a peripheral nervous system. Central nervous system demyelinating, you're looking at what typically? MS. What's a demyelinating, not too demyelinating it is, but a demyelinating disease that affects upper and lower. I'll give you a clue. One of its common names is named after a baseball player. Lou Gehrig's disease. Lou Gehrig's disease, or amyotrophic lateral sclerosis, ALS, right? That affects upper and lower. Guillain-Barré, we'll come to ALS later, but Guillain-Barré is a peripheral nervous system issue. Sometimes it's called acute idiopathic polyneuropathy. Acute idiopathic polyneuropathy. What does that mean? Acute means comes on quickly, right? Quick bout of it. Not chronic, it happens quickly, and usually it goes quickly. Idiopathic means no idea. I don't know where it comes from. Polyneuropathy, many places. Many nerves are affected. Okay? And so Guillain-Barré, acute idiopathic polyneuropathy. Another term you'll see for it, which is a good term for remembering the pattern, Landry's ascending paralysis. Landry's ascending paralysis is another term you'll see for Guillain-Barré. The reason why that's good in some respects is because typically the problem occurs in the legs and then ascends and it's in the arms later on, in the cranial nerves later. It goes up the body for some reason. So what you see basically is an acute inflammation of the peripheral nervous system. And the motor and sensory nerves are eaten basically, just like MS kind of thing. You get focal demyelation in various places. You find lymphocytes within the nerves. So obviously the most common, people think it's an autoimmune problem again. It's autoimmune, just like MS. Unknown etiology. We have no idea where it comes from usually. No idea, unfortunately. It's weird though, sometimes it'll often come after you've had an infection, often a viral infection. A week or so later, after a viral infection, people will develop Guillain-Barré. Sometimes it comes after surgery, for some reason. So no really why, but how that occurs, but and so basically the myelin sheath is just ingested by phagocytes. The myelin sheath is stripped away, eaten up, but the Schwann cell remains. Okay, so if you do not have myelin sheath, what's the big deal about that? You lose that signal. Remember that saltatory conduction we're talking about? So now you come to a section that's all been eaten up. So here's my axon. previously there was an myelin sheath there, but now the signal comes here, and now this is gone, so it dies off, and it can't get to the next node of Ranvier, so it just leaks away and it stops. Okay? What happens, you'll see that the symptoms usually start in the legs, and they progress up to the arms. You'll see sensory loss and you'll see motor loss. It gets obviously more severe if it goes higher up and gets into the cranial nerves. Then you're in a right mess. Okay? So then you think your facial nerve, your chewing, your throat muscles, speech will be affected. And the worst one will be to get into the vagal nerve, right? And so what you'll see in severe cases is wild, shall I say, fluctuations in blood pressure. Blood pressure goes up and down like crazy sometimes. You get respiratory problems, breathing issues. And that's what the cause of death is in some patients, loss of respiration. The muscles, going through the lungs and the heart basically don't get any activation and they just keel over. I think it's rare, but 3, 4, I think about 3% mortality with Guillain-Barré. That's when it gets serious and gets into the cranial nerves. Most people, though, recover. You'll find what happens is the symptoms gradually get worse. Motor and sensory symptoms will get worse for a week or so, maybe 2-3 weeks. Then they plateau, and then they get better. And a lot of people, there are no residual symptoms whatsoever. It's gone. Gone for good, and you're out of it. How is that recovery possible, do you think? Physiologically, what has happened, do you think? I've stripped your myelin away, your signal is gone. You can't get out. It can't get down to the next part of the nerve, and therefore you got weak muscles, right? How can you... In severe cases, the axon itself actually dies back. In very severe cases, the axon dies back. Okay? So obviously 2 things have to occur in a severe case. One, the axon has to grow all the way back down to where it came from, which is 1 millimeter a day, pretty slow. And you've got to remyelinate. Okay, you have to remyelinate. You have to rewrap those nerves. In the early cases, particularly in MS, another thing can happen. So here is a piece of axon that's been demyelinated. So I know it can't go down here because there's no sodium potassium pumps. And it's thought in some cases, particularly MS, these sodium potassium pumps migrate down into that area of axon which has no myelin. So now it can act like a normal non-myelinated axon. So you actually get sodium potassium pump channels appearing in the axon where the myelin has been stripped off, so you can get past that area. Does that make sense? Or you get remyelination, so you get rid of those symptoms, hopefully. I think in about 1/3 of people, roughly, you'll have residual symptoms, residual weaknesses, residual sensory issues in 1/3 of people. Usually they're fairly mild. Again, 3% will die. 10% of folk get what's known as a chronic, relapsing, remitting form of Guillain-Barré. So most people, it's gone for good. A few people, maybe 10% of them, get this sort of like an S kind of problem, where it comes back years later, or months later, or whatever, and they get this relapsing, chronic, relapsing, remitting form of Guillain-Barré. One of the most common ways, lots of ways to treat, but I say we're not going to go into all of that. But one thing that's often tried is plasmapheresis. Plasmapheresis, basically they take the blood out and filter it, essentially. They try to filter the antibodies out of it. Because autoimmune, you're attacking yourself, they filter the blood. And it supposedly helps to speed up recovery. For the surface, we basically want to treat the symptoms we're going to see, keep passive range of motion, modalities, heat, for pain and things like this, e-stim, for maintaining muscle strength, so it gets, when the nerve grows back, you've got a muscle to grow back to. Looking at strengthening, look at gait, looking at balance and things like this. Whatever you get, you'll see. And, hopefully most of these patients are going to recover gradually. So that's an example of so obviously this is a lower motor neuron issue as well as sensory issue. You're going to get those lower motor neuron symptoms, like your weakness, like your, fasciculations, like flaccid paralysis. And depending on the severity of it, of the lesion, you're going to get worse symptoms or whatever. Contrast that to an upper motor neuron lesion. The upper motor neuron lesion is a lesion within the cord, within the brain, within those corticospinal, corticobulbar, extrapyramidal, tectospinal, blah, blah, blah tracts. Okay? So it's a lesion within the cord of the brain, but remember, the lower motor neurons start in the cord, don't they? Lower motor neurons start in the ventral grey horn. So if I have a lesion, don't think lesion to the cord is only upper motor neurons. If I lesion this part of the cord here, I affect all upper motor neurons going to this part of the body. But I also affect the lower motor neurons at that one level. For that part of the body. Make sense? So, symptoms. You're going to see initially, let's first on the stroke, let's pretend. Initially you'll see flaccid paralysis typically. Now strokes are there's a wide variety of types of strokes, severity of strokes, so it's not as black and white as I'm going to make out. Okay? But generally speaking, you'll see hypotonic paralysis. You'll see flaccid paralysis initially for a day or so. But very quickly after that, you'll see spastic paralysis. You'll see spasticity, you'll see hypertonicity in those muscles. What's the difference between a rigid muscle, a hypertonic muscle, and a spastic muscle? And PT should know this. We talk about remote control. Hypertonic means increased muscle tone, right? Anything. Can mean lots of different causes of hypertonia. Spasticity is a specific type of hypertonia that you get with an upper motor neuron lesion, and that's when you get this non-linear increase in resistance as a result of velocity of stretch. A non-linear increase in resistance. In other words, the faster I stretch you, your arm, the more resistance you give back to me. I can stretch very slowly and you might not get any resistance. But if I stretch it quickly, it really gives you a lot of resistance. It's a non-linear increase in muscle contraction, stiffness, as a result of the velocity of which you stretch the person. And obviously it's thought to be, traditionally, a result of our stretch reflex. Because of the descending influences, the brain is no longer now controlling the segmental level. Those reflexes are allowed to go haywire. And so that stretch reflex goes round and round and round by itself, causing this massive spasticity in the arms. In the flexor, usually it's flexors in the arms, right? Extensors in the extremity, in the legs. Anti-gravity muscles are found to be spastic, usually. You can have extensor spasticity in the arm, whatever, but generally speaking, you'll see increased tone in the flexors in the arms, extensors in the legs. Okay? You will get rigidity in other kinds of diseases this is not spasticity. For example, I don't know, if somebody, a burn patient who sits in a wheelchair or whatever, get muscle contractions, muscle contractures, which give rigid muscle, but it's nothing to do with spasticity. In Parkinson's, you see cogwheel rigidity, right? Have you heard of cogwheel rigidity? So you try and stretch an arm of a patient with Parkinson's disease, they'll do this kind of thing. Cogwheel, it stretches, catches. Like that. That's called cogwheel rigidity. Or you'll get what's known as lead pipe rigidity in certain other diseases. Lead pipe rigidity is like you're bending a lead pipe, and it's just constant resistance throughout the range of motion. Doesn't matter if you try and stretch it slowly or quickly, you get the same resistance as you go. You'll see clasp knife resistance. Let me see if this works. This is a patient with upper motor neuron lesion. So you're bending it and whack, it suddenly goes. Clasp knife resistance. Like a pocket knife, you know, trying to put it away, and then boom, it goes like that. That's very typical of upper motor neuron lesion. Clasp knife rigidity. Another very common sign and symptom of a upper motor neuron is clonus, right? You've seen clonus, or you've tested for clonus in your scanning evaluations in the wrist and the ankle. This is clonus in the ankle. So the person applies one single stretch. The hand is not moving, it's the foot that's doing it, obviously. The hand gives a quick jerk, and the patient just vibrates against you as hard as possible. Clonus. Yes, you've seen that or heard of it, yeah? In your OTs, yes, you've heard of clonus? You do it in the wrist as well. Exactly the same thing in the wrist. You just grab the wrist and do that, and the patient will go like that against you. The wrist will just vibrate like crazy against you. Try again, that's clonus. Classic sign of the upper motor neuron lesion. You'll see this out in the clinic all the time. Your CIs will show you this. You'll have a patient who has a stroke, spine begins. So here, come and look at this. I'll show you this what clonus feels like. It's unmistakable when you feel it. Just as cogwheel rigidity is. It's hard to explain these, but when you feel them, it's obvious. This is the other. You'll see this one in the class. This is probably the most clear one to see, or most widely. Babinski reflex, Babinski sign. Yes, you've heard of this one? Where you scrape the bottom of the foot along a lateral border across the met heads with, what have you been taught to use? Reflex hammer, bottom of reflex hammer. You can use a whatever, your thumbnail. I think it's bloke's using. I think it's using his thumbnail. And what should happen to that foot? You get dorsiflexion and the toes will splay out. You get associated reactions in the left foot as well. The left foot this is the normal. That's what you'd see in you if you did it. The toes would curl down, you get, inwards, you get plantar flexion of the toes, but on the abnormal side, that's a positive. You don't have a negative Babinski and a positive Babinski. It's always just Babinski and that's it. Dorsiflexion of the big toe of the hallux and splaying of the toes, you'll see. Have you seen that? Have you been shown that before in your classes? Another one you'll find, Hoffman's sign. This is when you flick the middle finger and you'll see what happens. It's a very subtle one on this one. I couldn't find a better video. But you can see it flicking the bloke's middle finger and you get index finger flexion typically and thumb adduction. You see it, you've got, what's his index finger when you... Yeah, it's a bit fast there. You can see his index finger is flexing when you do that. And the thumb will adduct typically as well. That's Hoffman's sign. These are all classic tests for upper motor neuron lesions. You won't find any of this for the lower motor neuron lesion, right? So you're guaranteed to get a couple of questions on these in your board exams, from a PT anyway, I know that.
They usually just have like one of them, or if they have it, they have all of them. Like all these. Like, will they have a Binsky and Clovis? Or just
It depends, to be honest. I'd like to say definitely yes, but not always. Sometimes they will, depending where the lesion is, depending on the severity of the lesion, etc., etc. So you'll always see questions on this, I'd imagine. Most boards questions, exams I've seen, there's been a question on Guillain-Barré. The key to diagnosing Guillain-Barré would be an ascending pattern of weakness and blood pressure issues following a surgery. They'll give you a whole paragraph of stuff to look at. But in there, if you see ascending weakness, you see blood pressure fluctuations, and you see it occurs after some infection, throw everything else away. They're talking about Guillain-Barré there. Last thing. Well, it might take a while, but we'll start anyway. A couple of very common upper motor neuron lesion. Well, one is very common upper motor neuron lesion. This again is a classic question for you in your boards. You don't rarely see a pure ground acquired lesion, but be expecting to see one in a boards exam, because it's a good test of whether you know your neuroanatomy. So on the bottom, we talked about this before. In the very, very first class, we talked about a ground-acquired lesion, and that's showing a classic ground-acquired lesion on the bottom in the pink line. So what a ground-acquired lesion is essentially a hemisection of the core. One side of the core is completely sliced through in a pure ground-acquired. Obviously, you're not going to get exactly that, but let's pretend we do. So look what you've damaged. So here's the ground-acquired lesion here. I'll just put one in there. Okay, so you've got this cut in the cord somewhere. So all the upper motor neurons coming down there via the corticospinal tract, via the extrapyramidal tract, tectospinal, rubospinal, stop. Okay, we're making this black and white. Obviously this might not be a pure cut, some might get through, etc., 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 but we're making it black and white for now. So all those upper motor neurons stop there. So what would be the symptoms? Let's pretend that's in the middle of the thoracic level somewhere. T10, T5, whatever. Here is my arms. What motor symptoms do I have in my arms, in my left arm and my right arm? What motor symptoms? Do I see upper motor neuron problems in my left arm or lower motor neuron symptoms in my left arm? Upper motor neuron or lower motor neuron? Nothing. Why would you? Here are my lower motor neurons coming out. There are my upper motor neurons going to my arm. I'm exaggerating it. There are some ascending influences. You might see some mild, but pretend we're not looking at that. It's very basically left arm fine, right arm fine or not? Yes. What about left leg? What you're going to see is left leg. Motor symptoms. Spastic paralysis or flaccid paralysis. Is that a lower motor neuron problem or upper motor neuron problem for this left leg? Upper or lower? Where's the lower motor neuron? Starting segmental level, right? Is that affected? Not directly, is it? I haven't cut the lower motor neuron, but I prevented his upper motor neurons getting there. So what happens? You get that reflex arc going haywire, right? And you get spastic paralysis of his leg. Okay? That's largely due to which pathway of being affected. What's the most important pathway getting to that leg? Of motor neuron wise. Our lateral corticospinal tract is stopped. What about our ventral or anterior cortical spinal tract. Is that okay or not? For the left, remember that the anterior cortical spinal tract does not cross here. It does that, doesn't it? You got, 10%, 15% fibers. You get some signal down there from the contralateral cord, from the anterior cortical spinal tract. But the vast majority of your fibers are going to go to these lower motor neurons are chopped. And therefore you have upper motor neuron symptoms. You'll get Babinski sign, you'll get whatever down here, clasp-like reflex in that leg. What about my right leg? What symptoms do I see there? Upper or lower? Or nothing?
See lower. Lower.
Why? My lower motor neuron's here. Who's cut that?
Oh.
No lower motor neuron. Basically nothing. But remember I said there's always a involved and that's less involved? What is affected by this cut here, motor-wise? The anterior cortical spinal tract that's going to go over to that right leg comes down here and was going to cross over the segmental level. So you've lost 15% of the fibers of the anterior cortical spinal tract. But you're not going to really see much of that. You might, depending, but by and large, no symptoms in there. No symptoms. Lower or upper. Because my lateral cortical spinal tract is getting there fine. Does that make any sense so far? Obvious, isn't it? Yeah. I'll put the sense on that diagram. Brown's required now. We've got sensory issues too. And we'll do that next class.